functionally, we kind of continue endocrine therapies as long as we think patients are benefiting. Once we think patients have endocrine-resistant disease, that's when we're thinking about moving to cytotoxics, chemotherapy, or ADCs, right? We have multiple ADCs in breast cancer. I still feel slightly proud that we're still leading the ADC landscape and all the other tumors.
Tumor types, yeah.
So, we now have 2 FDA approved, TROP2, right? We have HER2. The thing about the HER2 and HER2 low and ultra low is that we see it disproportionately in HR positive compared to triple negative, right? So about a double the amount of patients that are HR positive will have it. And so for me, really, trastuzumab deruxtecan is my go-to ADC for HR positive. We can get in a whole debate about triple negative, which I don't think is in the scope here. But, I think compelling data, especially with DB-06 now.
Yep.
DB-06 looking at a little bit of, a different population than our HER2 low trial. It also looked at, the 0 with some staining, but also moved it up into that first line spot. And I think that's a little bit controversial. Are you going to give it first line or not?
So tell me about this.
Yeah.
So there is some data out there, reports out there that the academicians are not using it up front as much as the community. And you are, much like me, I feel like I'm quasi-academic, and I feel like you're close,
across the line
close to
depending
that too.
on how I feel.
Yeah. What do you feel about that?
I see it both ways, and honestly, I do both for patients. I understand the attractiveness of a capecitabine in HR-positive disease.
Yeah.
It's oral. It doesn't have hair loss. This is completely inappropriate, but I call it the gateway drug to chemo. And then on the other hand, there's a clear benefit with DB-06.
Yeah.
So sometimes kind of that patient in front of me, how old they are, what's the burden of disease, how quickly are they progressing, are they in trouble in the liver? Yeah. That'll influence me. But sometimes I have my patients kind of saying, no, I want capecitabine first.
Yeah, because they're coming off mainly all oral type regimen.
Right.
It's just very comfortable to continue them to oral, and they're asking whether they're oral types. DB-06, the only issue is really they had only about 3% bone-only disease.
Right.
And for that population that I've always felt respond well to capecitabine, I'm really leaning towards cape for those patients. The other I guess I tend to use when I need to for patients that have concerning visceral involvements. I would use T-DXd. I still do go for a little cape. Do you ever use a taxane instead of T-DXd?
No.
So once you're going from thinking IV, it's
Right.
T-DXd.
Absolutely.
Yeah, and so I feel that way too.